And we have the next session to be done by Dr. Vasant, who is a consultant physician from Amrita Hospital, a senior person. He's going to speak to us on postprandial hyperglycemia, the critical cog in the type 2 diabetes management. Dr. Vasant, please. And our chairperson is Dr. Sony Joseph, who is a consultant physician in Ernakulam Medical Center. Sony.
I think since the cricket match is going on, we wouldn't waste much time. My role is to just keep the match over right on time. Over to you, Dr. Vasant.
Good evening, everyone. At the outset, let me thank API Kochi and Novo Nordisk for inviting me here as a speaker. And I'll be talking on postprandial hyperglycemia, the critical cog in type 2 diabetes management. So first we will look at the relevance of postprandial hyperglycemia in the management of diabetes. Then we'll look at the complications caused by postprandial hyperglycemia and what are the therapeutic options that we have in managing it. So now if you look at this particular slide, you can see that there are two waves. One is blue and one is pale pink. The blue one shows you the postprandial glucose excursions in a normal patient, whereas the pink wave that you see is showing you the postprandial glucose excursions in a diabetic patient, and also you can see the basal hyperglycemia. So in a diabetic patient, the overall exposure to glucose is that of the physiological exposure and also the basal hyperglycemia as well as the postprandial hyperglycemia. Now what are the determinants for postprandial hyperglycemia? There are multiple factors. One is the basal glycemic level. Secondly, the insulin secretion and its sensitivity, glucagon and the other counter-regulatory hormones, and of course the meal size, the meal content and the duration of exposure to glucose, and also the gastric emptying time and the incretin hormones. So it's actually a play of multiple factors which determines what the postprandial glycemic level is going to be. Now coming on to the prandial insulin secretion, you have a cephalic phase of insulin secretion which is actually stimulated by the sight of food, the smell of food and also the taste before the gut absorption takes place. And secondly, you have the prandial insulin secretion which is biphasic. There are two phases. The first phase, which is the early phase, and it's transient, but that plays a very critical role in the control of postprandial hyperglycemia by probably stimulating the peripheral utilization by the liver for glycogen synthesis. Secondly, it also prevents the chronic postprandial hyperglycemia, the glucotoxicity, and the chronic hyperinsulinemia, that is beta cell exhaustion. The second phase is a more gradual phase and it is prolonged. So the release of insulin takes place gradually and over a prolonged period of time. And the amount of insulin that is released from the insulin islet cells is around, in the first phase only around 3% is released, and in the second phase around 20% of insulin is released from the islet cells. Now this graph looks a little bit complex, but you can see that there are multiple colorful lines. But the basic take-home message here is that with the number of years that a patient is diabetic, especially if it's not well controlled, then you are likely to have higher postprandial glucose values, which in turn leads to higher fasting plasma glucose values. So we should try to get a control of the postprandial hyperglycemia, and if you can do that, you can actually bring down your fasting plasma glucose as well. Now what are the recommendations from the various societies like the ADA, EASD, RSSDI, the American Association of Clinical Endocrinologists, the International Diabetic Federation? All of them, the recommendation is that the 2-hour postprandial glucose level should be less than 140 milligram per deciliter. If it's between 140 and 200 milligram per deciliter, then we call it impaired glucose tolerance. We're all aware of this. And definitely if the 2-hour postprandial glucose levels are above 200 milligram per deciliter, then it's definite diabetes. I think this is the old values itself. Okay. Now this is just some details regarding the DECODE study where more than 15,000 patients were recruited, and they were not diabetic. And the there were around 13 cohorts from 9 different European countries, and the assessment was the risk of death on exposure to hyperglycemia. Now, in this particular graph that you see, you can see there are a light blue line as well as a deep blue line. Now, as age advances along the x-axis, you can see that the linear increase in fasting plasma glucose is not very much. But if you look at the deep blue lines, that is reflecting the postprandial glucose values, as age advances, you can see that there is a linear increase in the postprandial glucose values to a greater extent than fasting plasma glucose, and it is more so in women. So, the increase in the prevalence of undiagnosed diabetes or newly detected diabetes as well as impaired glucose tolerance in elderly is mainly the result of an increase in the postprandial hyperglycemia which is occurring with increase in age rather than the fasting plasma glucose. Okay, so what are the complications of postprandial hyperglycemia? Now, because of the postprandial hyperglycemia, you have got oxidative stress which causes endothelial dysfunction. That leads to accelerated atherosclerosis, and obviously that leads to an increased risk of cardiovascular events. So, if we can control the postprandial hyperglycemia, then we can reduce the endothelial dysfunction, reduce the acceleration of atherosclerosis, and thereby bring down the incidence of cardiovascular events. Now, postprandial hyperglycemia triggers multiple pathways leading to cardiovascular complications. You can see that there are multiple pathways here. It leads to an increase in the insulin resistance. There is an increase in the catabolism of HDL, which is protective. It can lead to increased triglyceride levels, and also the lipoprotein LDL levels clearance is reduced. There will be increase in the free fatty acid levels, there will be increased blood coagulability, and all this leads to plaque instability and thereby leads to increased risk for cardiovascular events. Now, these are the various epidemiological studies which show that postprandial glucose excursions are associated with higher cardiovascular risk. The HOON study, the Honolulu Heart Program, the Chicago Heart Association study, and the DECODE study all show that postprandial hyperglycemia is associated with a higher risk of cardiovascular events. And postprandial hypoglycemia is also associated with microvascular complications. What happens is that when there is an acute increase in the blood glucose levels, it causes an increased glomerular filtration rate. So the mesangial cells are actually exposed to higher glucose concentrations, and that will stimulate the synthesis of collagen and worsens the diabetic nephropathy. So also the acute hyperglycemia increases the circulation in the retinal vessels, and that is a key pathogenic factor for the development of diabetic retinopathy. Acute hyperglycemia also will cause an impairment in the nerve conduction velocity of both the sensory as well as the motor neurons. So you can see that postprandial hyperglycemia is associated with worsening of all the microvascular complications. Now, this is an Indian study done by Dr. V. Mohan from the Mohan Diabetes Center, and it's been published, and it just corroborates what we just said earlier on, that postprandial hyperglycemia is associated with increased microvascular complications. Now, these are the details of the DECODE study. As I said earlier, it's actually 13 cohorts taken from 9 European countries, and more than 15,000 people recruited, and follow-up was for about 7.3 years, and the assessment is the risk of death associated with hyperglycemia, and postprandial hyperglycemic patients were seen to have a higher mortality rate. Now, if we take a look at this graph, along the x-axis you have the fasting plasma glucose, along the z-axis you have the 2-hour postprandial glucose values, and along the y-axis you have the hazards ratio for mortality. Now, if you look, as the fasting plasma glucose values increase, the hazards ratio go up. If you look along the y-axis, the z-axis, you can see that as the postprandial glucose levels also go up, the hazards ratio go up. But the hazards ratio is much more for higher postprandial glucose values when compared to fasting plasma glucose. So, for optimal control of blood sugars, we need to focus not only on controlling the fasting plasma glucose, but we also need to control or pay greater attention or focus on the postprandial glucose values, because we already said in the earlier slides that it is associated with a greater cardiovascular risk and also worsening of the microvascular complications. So we need to control not only the fasting plasma glucose, but we also need to focus on controlling the postprandial glucose values. So what are the therapeutic options to manage postprandial hyperglycemia? In type 1 diabetes, we can use the bolus insulins or the prandial insulins. You can use the regular human insulin and the rapidly acting insulin analogs. In type 2 diabetic patients, you have got multiple armamentarium. You can use the same bolus insulins or the prandial insulins. You can use alpha glucosidase inhibitor. You can use GLP-1 analogs, DPP-4 inhibitors, and repaglinide as well. Now, just taking a look at the insulin analogs and regular insulin, we all know that the insulin analogs, whether it is aspart, lispro, or glulisine, the onset of action is in around 5 to 10 minutes, and it peaks in about 1 to 2 hours, and the duration of action is for about 4 to 6 hours. Whereas the regular human insulin that we use, that is the Actrapid, that has an onset of action in about 30 minutes, and the peaks around 2 to 3 hours, and the duration of action is there for about 6 to 10 hours. So the issue with the regular human insulin is that it has a delayed onset of action. It peaks a little later, as a result of which you may not get a very good postprandial glucose control. And finally, because of the long duration of action, the incidence of hypoglycemia is likely to be more when compared to the insulin analogs. Now, coming to the newer fast-acting insulin, that is the fast-acting insulin aspart. It's the same rapidly acting insulin analog aspart, to which 2 excipients have been added, niacinamide as well as arginine. Arginine helps to keep the molecule stable, and niacinamide is an absorption modifier which facilitates a quicker absorption, and it also causes the hexamers to self-associate, from which the monomers are released. Now, looking at this slide, we know that once the fasting plasma glucose is not under control or the postprandial glucose is not under control, obviously the HbA1c is going to go up. But postprandial glucose values have got a greater or stronger association with HbA1c. So if we need to get an optimal control of the blood sugars, we have to focus not only on controlling the fasting plasma glucose, but also on the postprandial glucose excursions. And a good choice would be a premix insulin or a co-formulation. Now here we can see the biphasic human insulin as well as the biphasic insulin analog like your Novamix, and these are actually the molecules are often clumped, so you need to actually resuspend them, because you need to shake the vial and make sure that these molecules which are clumped actually dissociate, so that the pharmacokinetics of these molecules are not interfered with. But coming on to the co-formulation like your IDEC asp, which is a combination of insulin aspart along with insulin degludec, here a resuspension is not required because these two molecules do not clump, and so their activities are not affected. So it can be used directly. You do not have to shake the vial to dissociate the molecules. So to summarize, the glycemic control in a diabetic patient needs to be focusing not only on the fasting plasma glucose but also on the postprandial glucose excursions. That's because the postprandial hyperglycemia is, as said earlier, associated with increased oxidative stress, endothelial dysfunction, and also accelerated atherosclerosis, which leads to increased cardiovascular events and also worsening of all microvascular complications, be it neuropathy, nephropathy, or even retinopathy. And to optimize the control of sugars in these diabetic patients, it is better that we can use premix insulins or co-formulations. Thank you.
Thank you very much, Dr. Vasant. Since we are running short of time, we can have just one question. Anyone who have any comments or question, please. I think we'll go on to the next one. Thank you very much. Thank you, API. Thank you. No one orders.